All right, all right. Hello, everyone, and welcome to night four of National DNP Week. Tonight, we spotlight rural primary care and the organizational influence of DNP prepared CNS leaders. Please keep questions coming in the chat. Before we get started, though, we have a very special guest in Dr. Danielle McCamey, who will go over a brief history of DNP Week and talk a little bit about the theme as well. So, Dr. McCamey, take it away.
Well,
The
before
Dr.
I,
McCamey.
well, before I take it away, you want to introduce yourself to everybody?
Sure, I could do that. Thank you. So, I am Dr. Stephen Ferrara. I am a DNP prepared family nurse practitioner. I am immediate past president of the American Association of Nurse Practitioners, currently the Associate Dean of AI at Columbia University School of Nursing. So, that's a little bit about me, and thank you for reminding me to tell everybody who I am
And your illustrious co-host.
and my illustrious co-hosts.
Hello, everyone. I am Dr. Anyi Atabong, also a DNP prepared, dual board certified nurse practitioner, psychiatry and family practice, coming all the way from Maryland. I am an adjunct faculty member at Coppin State University and HBCU in Baltimore. And I also co-own a practice here in Maryland. And I am also one of the co-founders of we're a new organization, newly created, the Society of Psychiatric Mental Health Nurse Practitioners of Color. We are a year old, and that is thanks to Dr. Danielle McCamey, DNP's of Color, Society PMHNP's of Color. I know. We tried to find another name, but we couldn't. So that's where we are. We had our first summit in Baltimore, 120 nurse practitioners. It was amazing. We're going to be in Nashville next year. So please reach out if you have any questions or you want to join.
Awesome. I just love the DMP prepared excellence that you all exhibit. And I just think that's a test to us as those that decided to pursue the DMP degree, and also a great segue into why National DMP Week is critically important. And for those that don't know me, I'm Dr. Danielle McCamey. I'm an acute care nurse practitioner. I'm also faculty at the University of Maryland School of Nursing. I'm the inaugural Associate Dean for Clinical Partnerships and Innovation. I'm also the founder, CEO, president of DMPs of Color, and also the creator of National DMP Week. So thank you all for coming out tonight. Really, really excited, and we're going to have some great speakers and great conversation. But first, just want to just talk about the creation of National DNP Week, just so that everybody's aware, like where this come from and why we're celebrating. And so, the story behind National DNP Week. So last year, myself and Dr. Stephen Davis out of Georgetown, were creating a webinar that was speaking to the impact of DNP prepared nurses over the past 20 years, because last year was the 20th anniversary of the DNP degree being endorsed by AACN. And so we were talking, and I'm like, well, we should celebrate. And so we ended up kicking off the 20th anniversary of the DNP degree anniversary with a happy hour on the actual founding date. And as I kept marinating on like the month of October, I was like, the month of October is for DMPs, because um, DMPs of Color was founded on October 19th. We decided to coin October 20th as National DMP Student Day. And then October 25th was the official date of when AACN, the American Association of Colleges of Nursing, voted to endorse the position statement on the practice doctorate in nursing. And then last year being the 20th anniversary, for me, it was fitting just to start off DNP week with National DNPs of Color Day and end it on the 25th of the actual founding or endorsement date of the DNP degree. And so the DNP degree has been inception for 21 years, and there are more than 73,000 nurses that have graduated with the DNP, which is no small feat. And so last year, like I mentioned, we kicked it off with a virtual happy hour. Dr. Ferrara was one of our speakers. He did a toast, and we had a lot of other DNP prepared nurses from across the spectrum of practice, education, research, innovation there. So if you want to check out that happy hour, it was really, really fun. We had a DJ, we were Zoom dancing, so it was quite the celebration. And it likes to show the video for y'all, but we not gonna do the video this time. Maybe next time. Let me go back.
Sure.
It wants to show y'all the video again. All right. So, reiterating National DMPs of Color Day was this past October 19th. So, this is some of our members. Last year, we did a sneaker gala and we had our own custom Air Force Ones, which was really, really dope. National DNP Student Day. Shout out to the students in the building. And then just going over our theme. So this year's theme was where practice meets power, DNP's driving change. And it was incredibly important to highlight the unique impact of Doctor of Nursing practice professionals. And so this theme, we felt like it was a perfect intersection of really underscoring that DNPs are uniquely positioned because of our clinical expertise and our systems, healthcare education that we get from our degree, that the theme put together the power in our abilities to transform healthcare. In practice, obviously, a lot of us are still practicing in some way, shape, or form. And that clinical expertise and that experience really helps us to inform some of the evidence based knowledge that helps us with giving us that credibility and that unique insight to what actually works in clinical practice. And so, from the bedside to the boardroom, we know what really matters. And with that clinical expertise, we acquire power. And from that power, it yields leadership roles. It affords us influence so that we can utilize our insights for systematic and systemic improvements and change across healthcare. And so when you add our education with our experience, it equals tremendous impact. And then driving change. We're trendsetters, and you just heard our co-hosts and their mini resumes and their rundown of the different places and spaces that they utilize their knowledge and experience. And so with that, it positions us in very unique places and also opportunities to identify problems, create solutions, and make healthcare better for everyone. So we're change makers, not change takers. And so our impact, looking at this theme, it really celebrates that. It celebrates our leadership, our professionalism, and our contributions that we bring a unique blend of heart of bedside care, strategic thinking that's really needed to solve some of the big problems in healthcare that we're really going to be contending with come 2026. So we're going to be needed more now than ever before. But the theme just perfectly showcases our real impact that we make every day. So happy DMP week to everyone. And I hope you all enjoy the last day of our speakers. And I will stop sharing my screen and pass it over to our illustrious hosts.
All right. Thank you so much, Dr. McCamey, for sharing that. I am so excited to celebrate again next year. All right. So our first speaker this evening is Dr. Cameo Coleman on small town big impact and how rural primary care can deliver outsized outcomes through community rooted DNP leadership. So Dr. Coleman, over to you. Tell us a little bit about yourself and let's get into that presentation.
Okay, let me share my screen.
Yes.
Pull up my PowerPoint to share my screen. Give me 1 second. Can everyone see and hear me? No?
Yes, we can.
We can see you.
Okay, can you see the I forgot to hit share screen. I apologize. Of course. I was wondering, I was like, oh goodness. Let's see. Let me share my screen. There it is.
There we go. It's coming up.
Yeah, there we go.
Okay, and I'm gonna put it in presentation mode so everyone can really see it. Okay, so everyone can see and hear me.
Yes.
Great. My name is Dr. Cameo Coleman. I am so excited. I have attended every night of the second annual National DNP Week. And let me tell you, I do not plan on missing the third annual, the fourth annual, the fifth annual. I will be here, whether I am a speaker or not. Um, I'm just so excited that Dr. McCamey even created a platform of this magnitude, and that she will be sharing these videos out to let other DNPs know how we feel. So a little bit about myself. I graduated with my DNP, Doctor of Nursing Practice degree, family nurse practitioner, a specialty in 2015. I will say that my journey probably began in 2010 because at the time I was in nursing leadership as a nurse manager of a progressive care unit in the hospital. And my goal was to move up in leadership. I really had no intentions of practicing or being a provider. I really just wanted to move up because I loved my job at that time. So I applied to the Medical University of South Carolina in 2010 with the goal of obtaining my Master's of Science in Nursing Education, and I did do that. But at the time, I was awarded valedictorian, which was a pivotal moment for me because I got to sit with the president of Medical University of South Carolina during a luncheon, and we ate a Mediterranean diet. And he said, Cameo, we were crunching lab numbers. That's one of my favorite things to do, just talking about patient care. And he said, you're really smart. He said, I want you to check out our DNP program. And I was thinking to myself, well, what is that? And so I asked him, and he said, well, you'll be able to write prescriptions. I said, me? Right, with the prescription pad? And he's like, yes, I really think you should check it out. And we have 6 stipends worth $50,000 as a role to expand primary care in the rural areas of South Carolina. And so he did say, I don't know if you're gonna be awarded it was called the AANE expansion stipend, but you can apply. So I was one of the 6 students awarded this expansion to practice in primary care. And it enabled me to truly focus on the curriculum at hand, which was being a primary care provider. And during that time, so that started in 2012, I served as a presidential scholar, where I collaborated with multidisciplinary approaches from the College of Medicine, College of Nursing, College of Graduate Studies, dentistry, and even a few students from the Charleston School of Law. And so we had a year-long project where we helped the president, and we taught at a clinic called Abrazos for women trying to integrate into the American culture that is of Hispanic descent. So I really enjoyed it. And then they came back to me again and said, we've never had a DNP serve as a fellow. So here I go again, 2014, up into graduation, I served as a Presidential Scholar Fellow. When I graduated in 2015, I had a preceptor in the rural area of South Carolina called Bamberg, South Carolina. She really made me strong. I started out seeing 20 to 25 patients a day in St. Matthews, and I really enjoyed it. I really, really did. Because she had me prepared for joint injections, suturing, pap smears, prostate exams, basic diabetes management, hypertension, and I felt confident in that role. So that is a little bit about me. I will say that you will see the PMHNP degree. I did recently this year graduate from Purdue Global University, where I obtained my PMHNP degree to work as a psychiatric nurse practitioner. And while I was there, that was a great experience because I was a presidential scholar, presidential member of their National Honor Society there. So I also had a baby, and I am married. So a lot of people say, is it Dr. Green or Dr. Coleman? So it really doesn't matter. I'm just so excited. So just to kick it off, the name of my presentation is Small Town, Big Impact, the Power of Rural Primary Care. And I hope to emphasize that in this presentation. So go to the next slide. All right. So can everyone see that? Okay. Rule lessons. So in my DNP residency, I always hear people say, DNP is a terminal degree. It is. However, in family practice as primary care providers, we were required to attain another 1,200 hours on top of just, getting the degree. And so they entitled that the DNP residency. So I want to say that in rural healthcare, I did feel connected. I moved from Columbia, South Carolina, which is an urban area, to a rural area. And it shaped my whole experience going into rural primary care, where I was able to practice with a sense of community, humility, and resilience. And I will say that a lot of times people say, in healthcare, don't take anything personal. But in fact, we do take it personal, because we want to be able to cure our patients. We go home with the certain patients on our hearts, and we go home thinking, how can we help these people? So, a little bit of humor. So when I was attaining my DNP residency, one of the part of the practice was to, at the time I didn't have a license, so I would see the patient and then go back outside the room and tell my preceptor what I thought I should start as far as medication wise. So it was a young man that came in there, and he told me that his back was hurting because it was cotton season. And I was thinking, oh my goodness, I had passed by all of the different cotton fields. So I'm like, yes, his back is really hurting. So I went out, I presented to my preceptor. I said, I think he should have an NSAID, anti-inflammatory, and a short term muscle relaxer. I said, because with all that cotton he's picking, that must be hard work. At that time, I heard her pause, laugh, tell all of the other office staff. She said, Cameo, you realize they have machines for that, right? I had no idea. I did not know, but I will say, even though that was they were laughing at my expense, uh it allowed me to understand the context of the population that I was treating. So from there, I went back in the room, and he showed me videos on his phone of the machine and the lever that he had to pull, which caused the back strain. He did not have to pick the cotton. So I just wanted to share that experience. The scope of rural primary care: as primary care providers, we are diverse. We are treating patients in all walks of life, a lot of farmers. I also, when I worked locum at some of the primary care areas in the rural area, we had Hispanic patients. And the key with that was, if they had an issue going on and you felt like you wanted to prescribe a controlled substance, you couldn't a lot of times, because some of them did not have identification. And so that was a barrier there. However, I feel that you just don't say, well, you don't have any identification, I'm just gonna be through with this. You try to come up with different ways to help with, like, pain management, diabetes control, whatever they may have. So in a single day, as a provider, as a primary care provider, you are a clinician, you are an educator, you are a counselor, you are an advocate, and you are a community leader. I believe it's very important for people in your community to see you as someone that they can go to, they can talk to. So for example, I went into a few grocery stores, and I saw one of my patients, and she said to me, I had previously diagnosed her with cancer. And she said, Dr. Green, you saved my life. And she was smoking a cigarette. I said, well, I appreciate that, but you must have missed the smoking cessation part that I tried to teach you. And so we both started laughing. But that's how I am with my patients. If they invite me to church events, if they're selling like for children's candy bars, fruit, anything I can buy and give back, I try to do that in those areas. Also, a lot of times, because they are underserved, they may not have the income. So every year they have sports physicals, and a typical sports physical at like a convenient care may run up to $120. So one thing I do to help with costs is to do like a well child visit, so they don't have to pay and at the same time do the form, because it doesn't hurt to do the form. You're basically doing the same exam while helping them not have to pay the sports physical fee. So it requires some flexibility and empathy, and these two parts are not optional. It is essential. So rural care matters because 20% of the US population lives in rural areas. However, there's only 10% of physicians in that area. And by 2030, the national shortage of primary care physicians could exceed over 32,000 individuals. And so that is why being a doctoral prepared advanced nurse practitioner is so important in these areas. And we do serve as the primary access point for a lot of communities. Rural healthcare, it can be a challenge, but you have to meet patients where they are, and you want to create opportunities to provide primary prevention for a lot of these patients. For example, HPV. We have vaccinations for that. And so when you see someone that has not been vaccinated, you're trying to prevent them from, future cervical cancer or something of that magnitude. So clinical excellence through connection. You want to establish trust with people. You want to help them adhere to your plans. And patients, they may not forget your words, but they remember how you care for them. So even if you're having a bad day, I remember one of my family members being diagnosed with breast cancer in the middle of my clinical day. And although I couldn't control my emotions, I did tell my patient, hey, I need to step out because I just got a terrible diagnosis on someone that's very close to me. And they did understand. And then I was able to come back and finish the visit. But sometimes, I try to make every patient feel like they are the only ones that the only person I'm worried about at that moment, despite of maybe having 4 to 5 patients in a room at a time. But they don't need to know that. They just need to know that they have your time and they have your attention. So I could have in room 1, I could have a pap smear. In room 2, I could have simple diabetes management. And room 3, I may have a well child visit and a child running around. So it just, but from their perspective, they just want quality care. And I believe that we, as DNP leaders, we do provide that. So knowing my patients is very important. So 10 years ago, when the Affordable Care Act was really first started, the donut hole, oh my goodness, I didn't even know what the donut hole was, but I knew it was very hard for my diabetic patients. They were coming in with blood sugars, but they couldn't afford their insulin. They were coming in with blood sugars 300, 400. So a lot of the drug reps became my best friends because I was trying to speak with them so I could get samples for my patients. Now things have gotten a little bit better, I will say, but because they have different medications that that are preferred tiers. But 10 years ago, I feel like everyone was kind of trying to figure it out, like how are we going to meet the needs of these patients that can't afford their insulin. So like Monjero is expensive. So you must have financial awareness. You must offer, affordability. I've had clinicians where I've heard them say, "Well, I just prescribe it and I don't worry about them paying for it." Well, if you prescribe it and you don't worry about them paying for it, when they come back, you're going to be worried about trying to get their A1C down or their glucose level down. So I care, as a primary care provider, I care about every aspect of their life. And you want to integrate evidence-based practice. So I also serve as a lead adjunct professor at Claflin University, and I'm really big on telling my students about evidence-based practice guidelines, literature. We don't just go and prescribe any type of medication. It is pathways as to why we derive to certain situations. So for example, lipid panels, I'm constantly looking at AHA. I'm looking at different resources. with lipid panels, what I try to do in any labs, I try to print the labs out for the patients. And so most of the time I get the same comment: is the HDL the good cholesterol or bad cholesterol? Or is the LDL the good cholesterol or bad cholesterol? And then I go through and I talk about LDL, and they say, well, how can I get it down? I say, I'm about to go through there. I'm about to go through there. So let me just tell you, you want to cut back on bacon, sausage, fried fish, fried pork chop. And they just bust out laughing because I put it in a layman terms where they can understand it and where we can both understand it. Like I tell them, you may not put down every piece of pork chop, but you can cut back and you can start baking your food. So, what I enjoy is when the labs are printed out and patients see something bolded in bold print, and they say, why is this bold? I love when they ask me that, because that lets me know that I have taught them some form of health literacy where they are now empowered to drive their care. I do not want to be a clinician that had a patient that has a high potassium level, and we didn't address it. So most of my patients, I teach them about the labs, and then they come back and they tell me what they have done about, like, what they have done in their daily routine to try to improve their labs. So evidence-based practice is not just research, it is a science that I feel like we should really read about and adopt methods. Another thing is, a lot of times with working, for me, sometimes working in psych, when you're in a different discipline, you can let one part lapse. You want to, every time I get articles on Doximity, it doesn't matter whether it's about primary care, psych, I'm reading everything because I never know what I'm going to run into in the course of a day. And so there is a human side of clinical care. So for me, if I have a patient that I am diagnosing for the first time, for example, an X-ray that says this is a spiculated mass and it's highly suspicious for cancer, this person may need a family member to come and hear these results. And a lot of times when you tell patients, I'm going to refer you to oncology, I'm going to refer you to another specialist, they feel like, you're giving up on me. And I have to reassure them, look, one part of me referring you, I'm still the cook in the kitchen. I want to get all of the notes back from the different doctors. And if I do not get or providers, and if I do not get those notes back, then yeah, it is a problem. I'm reaching out by phone. If I have to skip a lunch break, I want to know about my patient and what happened when you set your eyes on that patient. And then when they come back to me, I can say, hi, so how did that consult go? Did they treat you well? You want to have these relationships. I had one X-ray radiology physician. He said, hey, Dr. Green, I know you. I held the patient right here until I talked to you, because that was me. I'm just calling all over, making sure that I make contact with the referring provider and I understand what is going on with my patient, despite of me making that diagnosis or not. I do believe in a multidisciplinary approach. You cannot do everything yourself. So oncology, podiatry, ENT, behavioral health. I never forget one of my first clients that I saw came into my office for diabetes management, and she started having hallucinations, and it was very, very, very scary. But fortunately, I had the contact number of someone in psychiatry, and I was able to send her right there. So you want to make partnerships. You want to talk about the nearby hospitals in a good light. And if you find something that, because ultimately patients in the rural areas, if they hear something negative about a hospital, they're like, I'm going to just dodge that hospital and go straight to the big city. But that may not be the best for them. They may need to go to the closest hospital and stabilize. So if I'm talking poorly about a different department or a hospital nearby, and it's something that I have a problem with, I feel like it is my job as a primary care provider to go to that hospital and find out what can I do to improve communication, and what can I do if my patients have urgent needs to help you meet their needs, and we can both meet them together. Because I want to talk up any institutions that are nearby and any providers that are nearby. So leadership is key with the DNP role. South Carolina is a restrictive state. So we are not, I do have licenses in full practice states, which means I do not have to have a collaborative physician. However, I think one of the states I applied to asked the critical question, are you willing to communicate with a physician? I'm like, sure, I'm willing to communicate with everyone. So, advocacy groups are important to improve autonomy in this state. DNPs of color, that was one of the first organizations that I saw online that really spoke to me. And I plan to support this organization really as long as I live. I really like what Dr. McCamey has done. And of course, the AANP, I'm certified by the AANP, and I really found that a lot of them do understand where I'm coming from when I say, hey, this patient had critical labs, and what do you do in that case? So you really want to, fellowship with other people in the profession to improve policies around the state and your environment. So the role of a doctoral prepared nursing leader, we are innovators, we are implementers, and we influence, and we lead, and we transform policies. Let me tell you something. If I'm working at an organization and there are policies and procedures that I do not agree with, I'm very wordy. And so I will take it back and I will say, hey, we need to do a practice change. Whatever board I need to go before, I need to tell you that this needs to change because I want this patient to have this type of workup if this happens and comes through my front door. I want to recognize, I know I've said her name a few times, but Dr. McCamey has been phenomenal. She's the founder, the CEO of DNPs of Color, and she also is the founder of National DNP Week. And just to do something of that magnitude just gives me chill bumps as I'm talking right now. So I want to make sure that I support this every year from a financial standpoint, from a physical standpoint. I want her to know that she has my support because before she really came around, I would say I have a DNP, but I didn't see it really broadcast as much as Dr. McCamey just comes on LinkedIn and just says, this is the DNP role. But this is what we need. This is what we need to diversify. This is what we need to make a difference. So just closing remarks, because the attention span of an individual is 8.25 seconds, 8 minutes and 25 seconds. So I don't want to hold you any longer than what I have to, but I want you to get across that being in rural primary care is about service, it's about communication, and that we have a vision that can reshape how we deliver care today. And leadership doesn't mean that you're always in the spotlight. Like I said, it's okay to be in the background cheering on someone like Dr. McCamey and my other colleagues on this Zoom call. Thank you and happy National DNP Week.
Thank you. Thank you, Dr. Coleman. That was amazing.
Thank you so much.
Such great perspectives. And for somebody, you've had the ability to see both, an urban setting as well as a rural setting, and quite the difference, I'm sure.
Yes.
So you being able to bridge those gaps and share your experience is just amazing. I can't not say, because of my health policy piece, our titling is under threat today. I'm sure it's been said this week. But we know that there was a case that was heard in California that prohibits DNP, doctorally prepared nurse practitioners, from using the title doctor in clinical settings. I am just going to say I'm extremely disappointed in that ruling. And I believe that all clinicians should identify the discipline in which they were trained and educated in. We have work to do, and that work begins with each and every individual one of us. So I'm going to step down off my soapbox for the time being. Yeah.
I'm with you. I mean, I've probably dropped the title in South Carolina just because it's a restricted state.
Yeah.
But a lot of times, I've had one of my old preceptors pull me aside and told me that she was a seasoned nurse practitioner, and that she really told me I needed to go by Doctor Cameo Green Coleman. And sometimes I will say it, or patients really, they'll look at your code and they'll say, what's that D? That D has to be for doctor. These patients
Mm,
know, they
they
know.
do know. They
So
do.
I really feel like we have so much power in our hands until it's going to change. I really do believe that.
Absolutely. I agree.
And
Dr.
I forgot
Atabong,
I'm open for questions. I forgot.
yes. So please feel free to unmute yourself if you have a question, or write a question in the chat box. Don't all ask at once. I always love to say, if
I
it was
see.
if this was my DNP health policy students, my thread is we don't leave until somebody asks a question. So
And
maybe
I want to thank my family for coming on here. I see that they uh are joined, and I also want to thank Claflin University Nursing Department. I've been with them for 6 years, for supporting me. They posted it on their Facebook page, and so I really just appreciate the support. I really do.
Is it the RBC Powers? Am I saying that correctly? Is that Claflin? Because they've been throwing hearts throughout your whole presentation.
I don't know, to be honest.
Okay.
No, I just love her presentation.
Thank you so much.
Thank you. That's nice.
awesome.
Thank you.
All right.
All
Dr.
right. Well, thank you again, Dr. Coleman, for that awesome presentation and sharing your journey.
Thank you.
Next up, our next speakers here, Dr. Tracy Montesa. I hope I said that correctly. If not, you can absolutely correct your last name. Clinical nurse specialist in adult acute care, and we'll be talking on measurable organizational impact, reducing harm, improving coordination, and driving EBP, QI, and research through the CNS's three spheres of influence.
Thank you so much. I appreciate you guys having time for us to share this presentation. I couldn't do this work without the team at my hospital, so I really want to recognize all of the people at Lutheran General Hospital. Some of them are here on the call today, and also want to say thank you to my family. I see them on the call as well. So I will try to share my screen here. And get this presentation up.
We're good. We can see it.
Okay, perfect. So hi everyone and good evening. Thank you so much again for having me tonight. My name is Dr. Tracy Montesa. I am an advanced practice nurse with certification as an acute care clinical nurse specialist. I earned my doctorate at Rush University in Chicago, and I'm currently working at Advocate Lutheran General Hospital in Park Ridge, Illinois. I just had my 6-year anniversary last week working in this role. So I'm so grateful that this opportunity aligned with that milestone event in my career so I could engage with all of you and share some important pieces of this role that I've learned along my journey. And so before I begin, I also just want to thank the organizers and moderators of this event for all of your hard work. It's been an incredibly inspiring week. I've listened back to some of the recordings, and I'm honored to be your closing speaker. So let's begin. Whether you're in transition to practice to complete your doctoral program, or early in your career as a DNP looking for guidance, or a seasoned DNP looking to connect to purpose, I hope that sharing my experiences today is going to help and encourage you to collaborate with more clinical nurse specialists in your areas and across the nations. For this presentation, I have nothing to disclose. And so tonight, you are all cordially invited to the wedding of a clinical nurse specialist and the DNP degree. I'm here today to show you why these two are a match made in heaven and how they bring out the best in each other. At their fullest potentials, which is top of license practice, paired with the terminal degree, this creates a power couple that can transform healthcare, where the CNS is the heart of clinical expertise and the DNP is the driver of leadership and innovation. When clinical mastery marries visionary leadership, the future of healthcare is born. To really understand what a clinical nurse specialist is, first we look under the category of our advanced practice nurses. We know that the public is very familiar with nurse practitioners who are primarily patient facing, but not all advanced practice nurses are only nurse practitioners. We have certified nurse anesthetists in our procedural areas and certified nurse midwives in our women's health areas. And then we also have the lesser understood but highly important role of the clinical nurse specialist that balances three distinct spheres of influence. We impact systems, nursing, and patient. So on the left here, our National Association of Clinical Nurse Specialists outlines these CNS core competencies. Under the patient direct care sphere, we see that CNSs who are practicing at full scope, these ones can provide direct specialized care to patients and assist nurses with direct patient care. They can consult on complicated cases as content experts, and many of these CNSs have prescriptive authority within their states. Within the nursing and nursing practice sphere, our CNSs are the go-to experts for other nurses in practice areas to ensure that standards of patient care are met. We function in 5 sub-roles, including being an expert in clinical practice, being a leader, a researcher, an educator, and a consultant. So that's why you see, if we're ever referred to as an educator, it's so much more than that and so much more deeper layers than just being labeled as an educator. At the organization and systems level, CNS work within interdisciplinary teams to make improvements within their organizations, such as designing and implementing new evidence-based practice guidelines, policies, and procedures. And as we move through these 3 spheres in different ways each day, we're applying our knowledge of evidence-based practice and keeping that as the priority while we weigh our decisions. Next, we look at the core of the DNP curriculum. The combination of a CNS and a DNP creates a powerful synergy that enhances healthcare delivery in so many transformative ways. So here's why the blend is so impactful, and we'll start with the upper left-hand corner. When we look at evidence-based practice implementation, we have a CNS who can quickly identify gaps in clinical problems and who are the experts in implementing solutions. With that DNP degree, you also get that training to critically appraise the research and translating that evidence into practice. This is a skill that takes a lot of time to finesse, and that's why it's critical to have a DNP in your corner. This combination ensures that interventions are both clinically sound and grounded in the latest research, so we know that we are truly doing what's best for our patients. Clinical expertise is next. So what happens when this meets system level leadership? CNS focus on improving patient outcomes through advanced clinical expertise, their education and consultation with a specific population or specialty. With a DNP degree, this equips that nurse with high-level practice-focused education, emphasis on leadership, EBP, adding in health policy, and then systems thinking. So together, they're able to enable that nurse not only to provide expert care, but also to lead improvement across healthcare organizations. Next is quality outcomes. This is the powerhouse of improvement and innovation. CNSs often lead quality improvement initiatives at the unit or organizational level. And with the DNP degree, this brings advanced skills in understanding different change frameworks, project design, data analysis, evaluation, and my favorite, placing importance on that sustainability plan. Together, they are the catalyst for the change to occur, and they drive that sustainability to improve patient safety and satisfaction and can reduce costs. Lastly is the organizational impact. So CNSs can serve at system level as system level change agents, and their focus on evidence-based practice implementation leads to positive impact with cost savings and process and performance efficiency. DNPs are trained in organizational and strategic leadership and change management, policy and advocacy, and data-driven decision making. This combination fosters a highly collaborative nurse who enhances team performance and aligns clinical practice with the strategic goals of the organization. Whew, that was a mouthful and a lot to take in for you guys, I'm sure. So I'm going to spend some time also going through examples of what this means in real life practice. So I'll use what we've done at my organization, kind of help pull it all together. So as a clinical nurse specialist in our hospital, I chair our Nursing Research and Innovation Council. I also help to lead our Happy Sprint team, which is our hospital acquired pressure injury team. And I have unit specific ties to our surgical ICU and our neuro ICU. So I do want to emphasize that all the projects that will be explained in the next slide are all team efforts, many of them multidisciplinary. And the goal here is to highlight how having a DNP prepared clinical nurse specialist can help augment these teams to be a little bit more effective. All right, so in the evidence-based practice sphere, this is my student, Jenny Tokarski. She is a DNP student, so part of our CNS role and uplifting other DNPs is to mentor them. We went through the EBP process of, looking into the literature, critiquing the evidence, and her project was about in situ rounding education. She found a lot of literature supporting that education cart going around the unit, and she did pre-tests and post-tests on different education she wanted to prioritize based on her learning needs assessment, which included respiratory, hands on the Zoll, defibrillator, and emergency response, and EKG rhythm recognition. She was accepted to the National Teaching Institute, which is one of the largest nursing conferences similar to Magnet. And she will also be doing a podium presentation soon at the virtual conference for Advocate Health next month. So she additionally then also used her own EBP to create a language service education cart and had really great influence of her interpreter service resource toolkit in our MICU and our Med-Surg floors, which have the highest rate use of interpreter services. So I was able to mentor her through the design, the process, really gave her the autonomy to implement. And then we would come together to discuss those results and see how we could sustain that project, make it more applicable to other units as well. So we will be handing off some of that sustainability to another DNP student who will be coming on to take a look at the remaining units who need support in the Med-Surg areas. So that's one example in our evidence-based practice wheelhouse. Then clinical expertise. For this one of the examples that we wanted to use was evidence-based practice under understanding the roles and responsibilities around our ACLS performance. So I'm not sure about the rest of you, but our institution went to resuscitation quality improvement, which is a quarterly competency with hands-on training and a didactic learning on our EMR. Well, this really took away the hands-on portion of how we provided support to our frontline staff. There is a big gap in understanding what's my role when I enter the room, We saw communication breakdowns and did debrief. People weren't leading, people weren't communicating with each other. So this simulation was initiated to kind of pull those things together. We spent a lot of time on the design of this project. I want to say it was 6 to 8 months of just going over the design itself and the clinical expertise of all of the people involved. It was a multidisciplinary effort, but specifically with our nursing professional development specialists and clinical nurse specialists, we came together with our clinical expertise to say these are the things that our nurses need to know. And we critically appraised. My role in this was to also critically appraise and synthesize the literature for this project, where we found that rapid cycle deliberate practice was going to be the best aim for the megacode situation in particular. So rapid cycle deliberate practice is where you will initiate the simulation and then you will take a break at certain points, coach the team, give pointers. They'll have those pearls of wisdom to take into the next round and you'll begin again. So it's a layered approach to learning so they could stack all of those learnings up and hopefully by the end execute flawlessly, which 99% of them always do. And then you can see we disseminated this project as well in our internal symposium, which we also initiated at our hospital. We'll get to that in a little bit. And these are my wonderful teammates. Angela's inside the simulation room. And then on the right side, Markar is one of the NPDSs that we work with. And Debbie is one of the CNSs who is also working with us. This one for quality outcomes, I wanted to just highlight the work that we are doing in our Happy Sprint team. So our sprint team is essentially making short goals to get where we need to be and meet our metrics quicker. And this team was just formed about 2 months ago. And we quickly had to figure out what we were doing. And I served as the basically project coordinator for this. There's a lot of moving parts. We had a new group of stakeholders that we needed to introduce what even is a sprint team. We developed our roles and responsibilities. We also acquired Happy Champs, who their structure had just recently changed as well. So how are we going to marry the Happy Champs with the Happy Sprint team and what are their roles and responsibilities? And amongst doing all of that foundation laying, we also had to quickly launch 2 simultaneous initiatives that were going live in a short time span. So we had staging practice, staging pressure injury practice change that just rolled out. And we were also identifying from our prevalence studies quarterly that we were trending, that we had 2 units that were severely falling out, and those Happy Champs needed to go through an auditing process, which we would train them up for. So a lot of wheel spinning, and my role was to make sure that all the processes were sound and in place, that the education was going to be relatable to the frontline staff when we pushed it out. So we got a lot of feedback from them as well before we went live. We also wanted to reinvigorate our Measurement Monday compliance, where all the wounds would be measured. And then since we got cited for in our regulatory for our wounds being documented on admission, that's another corrective action plan that the CNS can also help to close. Organizational impact is my favorite sphere. This is where I feel like I function the strongest. And some of these examples that you'll see, again, they're multidisciplinary efforts. But for increasing clinical inquiry, the Nursing Research and Innovation Council is something that I chair. I'll be quite honest with you, I wasn't very excited about this when I first started as a novice CNS. This is something I was hoping to grow into very slowly and had to grow into very quickly and learn to love it. But eventually I had learned to love it. So we got into a really good spot, and I got to see some of my skills really come to life through working on projects in this committee. Um, so I will share some of the things that we've accomplished. This committee had not been meeting previously. They were really having low attendance. We switched up the stakeholder groups, made it more applicable to people, got the right frontline staff involved, and now we are sustaining 90% attendance rate with frontline involvement. We've gotten frontline nurses to lead journal clubs, which is incredible to see them go through that process and really understand how to read the literature and teach others how to go through it as well. We've taught others how to write and review abstracts. We have an internal fellowship program that was not being really taken advantage of, and we promoted it a lot and encouraged and mentored these fellows last year. So we increased our fellowship from 2 to 8 this year, which is a huge increase. We created our own internal symposium, which was a huge feat in and of itself to get the buy-in for last year. And we launched it, and it was so successful. We did it again this year. We were able to get our keynote speaker, who was the CNO of all of Advocate Health, to come and support us. We had a lot of leadership from our internal sites come over and support us with that as well. And our project submission grew from last year to this year. And within our committee itself, we've also engaged our committee members through our education and micro-learning sessions, workshops, and we've had an escape room last Christmas, so I think we'll try to do it again. So this work was presented also nationally at the AONL Professional Governance Conference. Another organizational impact that we helped with is the closure of regulatory findings. So on the unit that I work on in neuro ICU, we were looking at our VASC band removal documentation, and that compliance was as low as 15% at the beginning of January 2024. Slowly but surely, we did a PDSA cycle and got that up to 84%. And I'm very proud to say last month we hit 95%, which is the first time we've ever been above 90%. And I'm hoping we can sustain it. This work was also disseminated locally at our Rush Symposium. This was the neuro ICU manager's first time disseminating her work. So very proud of her for getting out of her comfort zone and presenting that work for her team. And then lastly, the division, critical care division, worked to close a regulatory finding with the drip titration documentation. These are the various groups of documentation we were looking at: the start dose, pre-titration assessment, post-titration assessment, and the dose matching the order. And you can see all of these had increased over a very short time of us auditing and launching a lot of PDSA cycles to ensure that we could close this finding. And I'm very proud to say that this was one of our site awards for Stronger Together. That recognizes a multidisciplinary team coming together to work on a project and create successful outcomes. So overall, I just wanted to thank my team for entrusting the role of the clinical nurse specialist. There's a lot of work that we can do. Like I said, organizational impact is my favorite because I love to see other departments coming together, multidisciplinary teams coming together, and making that change across the house. That's something that I am really passionate about. But even more so than that, not keeping those secrets at site level and really encouraging others, even though they feel that it's scary, to write those abstracts and get that work out there, because you need to share all of the work that you are doing. And that's something that I feel a DNP and a clinical nurse specialist is really strong at doing, is encouraging others to present their work nationally and make sure that everybody has the tools that they need to succeed within their own organizations. So, lastly, I'd like to acknowledge my team and also my mentors, Stephanie Zydak and Marianne Moon, who really helped me early on in my career to get squared up and go down a good path of reaching these goals and working within a large organization. So thank you so much. And I would love to stay connected with you. If you would like to connect through LinkedIn, you can scan the QR code here, and I'm happy to chat about anything and swap ideas and maybe even partner up in the future. So thank you so much for having me. It means a lot. And I hope you have a great rest of your DNP week.
Dr. Montesa, thank you, thank you, thank you. That was a phenomenal presentation, very thorough. Thank you for sharing how impactful the CNS role is in our community. I know a lot of us who may be in outpatient private practice settings, we kind of forget about the CNS role, right? Because I know a lot of us may see you more in acute care settings, hospital settings, but the CNS is quite robust.
We wear a lot of hats. It's a busy, busy job. I'll tell you
It
that much.
is.
You never rest.
It truly is. Let's see if we have any questions in the chat. No questions in the chat. Does anyone have any? You can unmute yourself and please.
Promise I'm friendly. I don't bite.
Yes. No questions, y'all. Y'all shy. Y'all being shy.
I'll just say I really enjoyed it. I think that oftentimes we hear DNP and just think providers as far as like nurse practitioners, but you talking about your role really opened my eyes. You all you do a lot. So thank you.
Yeah, we love partnering with you guys too. As the clinical experts, you are big, big, big parts of all of the projects that we run. So we heavily rely on each other to make these changes within the organization. And I hope if you ever come across a clinical nurse specialist that you grab that opportunity and say like, hey, I got an idea. Let's do this, because they are game, let me tell you.
Thank
Well,
you.
oh, I'm sorry, Dr. Cole. So, well, I just want to say great presentation to both of you. Dr. Cole, thank you so much for the work you're doing in areas that otherwise get overlooked in so many ways. I like how you're collaborating with other disciplines and other specialties to give your patients the best care. I can't thank you enough for what you do. Plus, my husband is also from South Carolina, so who knows that that your work is impacting my family on one side, right? So thank you so much for all that you're doing. And for Dr. Montesa, did I say your name right?
Montesa, yeah.
Montesa. Okay, so if I butchered your name, I apologize to that. Um, Thank you so much for the work you're doing in your hospital advocate as well. For me, regulatory is huge for me. And sometimes I think the question you get with people that people ask me all the time is, how do you have a DMP and you still work in patient safety and quality, right? But I like what you're doing. I'm happy to hear that the other people out there, CNS role is really huge because you're bridging the gap between clinical and patient safety and quality. And you, with all the things you shared with us tonight, you and your team are doing amazing job there. Continue it. I like that collaborative effort, that cross-functional cross-functional collaboration to just ensure that things are being done, especially bridging all those findings from your joint commission findings. That's really awesome because what you're doing is bridging the gap between practice and what is really expected of us to do as clinicians. So thank you all. And I think I'll be amazed if I don't say thank you so much for Dr. Is it Dr. McCanny or McCamey? So sorry, I don't have my glasses on. I can't see too well. So I know yesterday, I believe yesterday, um soon to be Dr. Nixon stayed in, and I want you to know she did an amazing job hosting it. She did great yesterday, and I'm happy to see you today because it means that you're like, no matter how tired you were, as we were we heard a little bit about how busy you've been, that you made it through and you've still shown up here. Thank you so much for putting this together. For somebody who's new to LinkedIn or any social media for just for the past 1.5 months, if not for anything, I'm so happy I joined LinkedIn because I never even heard about DNP of colors. And I would appreciate it if somebody could just put a link or something in the chat or something how to get membership. Thank you so much for all that you're doing, as well as all the organizers, the host, and everybody. I will leave it because I don't want to take all your time. But thank you so much.
Oh, thank you so much. Yes, so Dr. McCamey put the membership link in the chat. Yes, we want members. We need membership dues so we can have more conferences, more meetups. We can advocate for policy in reference to DNPs, like Dr. Ferrara mentioned earlier, about how the title of doctor is not welcomed in certain practice areas. And we are doctorally prepared clinicians. We should be equally using that title as well. Like the PharmDs are using it, the PhDs are using it, the occupational therapists with doctorates, the physical therapist. So what is wrong? Why y'all coming for us? They mad, they jealous. Y'all jealous of the nurses? But anyway, this was amazing. Dr. Montesa, thank you so much. Dr. Coleman, thank you so much. Your presentations were very impactful, very powerful. Shout out to Dr. McCamey because this week you really highlighted different arenas of nursing. So she went from wound care to burnout for clinicians to with policy to you all doing rural care and then the CNS role. So it's just beautiful to see how powerful and the different diverse arenas that we are, that we're all in. So again, thank you all so much. Happy National DNPs of, I was gonna say DNPs of Color Week.
I mean,
It still works.
Right? It still works. Happy National DNP Week. We are looking forward to doing this again next year. Please join us on LinkedIn, join membership. Don't forget, link is in the chat, click on it. And tomorrow is happy hour. So tune in for the last day. We're gonna do happy hour. So Dr. McKay, we're allowed to bring drinks, right? I can bring my wine.
So tomorrow's happy hour is going to be innovative in that it's going to be an asynchronous happy hour.
That still works.
We couldn't get a bartender, so we're asking people to post their toast on our LinkedIn page. So there's going to be a post early in the morning that's going to tell you about our two cocktails. We have one cocktail called the Power Shift and a mocktail called the Practice Punch. So if folks will indulge us in creating their cocktail or mocktail and post their picture and their toast, it will be our first asynchronous happy hour because sis is tired and sis will not be available for Zoom tomorrow for the happy hour. But I did want Dr. Atabong to make the announcement. I sent you a message if you could close us out with that message in your DM on the Zoom, the chat.
Uh-oh. Okay. Oh my gosh. In the Zoom chat? Where are we? Let's see here. I missed it. Sorry, guys. I was running my mouth. So the happy hour. Uh-oh. Next year's conference. Hold on,
Theme.
guys. Ooh, this theme, y'all. Ooh, so the DMPs of Color Conference next year.
No, not the conference. It's not docs. This is National DNP Week.
But still, though, I wanted to just still announce the conference, y'all. So please come to Detroit next year. October 15th to 18th, right, Danielle?
Yes.
You should still throw that out there. I know this is DNP week, but DNPs of Color has their conference in Detroit next year. But then the theme for next year for National DNP Week is Designing the Future, DNPs Leading Systems, Science, and Social Change. So I can only imagine what the lineup is going to be for next year. Yeah, that lineup is gonna, Dr. Ferrara, you're gonna have to be in here with your AI. You're going we're gonna need some AI up in here. What?
It'll be everywhere by then.
Right. So that's gonna be our theme for next year. I'm so excited. Again, thank you all so much for taking the time to join us on a Thursday evening, because I know you all worked and saw patients or saw students. And so again, have a wonderful evening, and we'll see you all tomorrow if you're joining. If not, next year.
Thank you.
Thank you. You're on mute, Danny.